Our final speaker before the panel session this morning is Leona Ryan. Leona is a PhD scholar at NUIG and a psychologist. Her work focuses on the enactment of weight stigmatising behaviours by healthcare professionals in healthcare settings, and she looks at it from the point of view of the person living with obesity. So this morning we're going to hear a little bit about that work and really from the lens of the Irish adaptation of the clinical practice guidelines that have been recently been published. So you're very welcome, Leona, and thank you.
Hi, my name is Leona. Thank you for introducing me. I'm really nervous today. This is the first time outside of COVID I've attended a conference, so it's strange to see people in real life, but lovely too all the same. So I am a PhD candidate and psychologist based in the wet west of Ireland in the University of Galway, formerly known as the National University of Galway, and I'm a research associate with the Science Foundation Ireland Centre for Research Training in Digitally Enhanced Realities. What we're working towards is creating a digital intervention to deliver a weight stigma reduction strategy for GPs to improve the provision of care, essentially through obesity education and training that will improve the provision of care, apologies, for overweight and obesity, while also simultaneously improving the skill set required to do so. A lot of obesity stigma research to date is theory-led and quantitatively driven, which is fantastic because it gives an idea of the magnitude of weight stigma. What we were interested in looking at is a weight stigma from the patient perspective. Explicitly, we were interested in looking at enacted weight stigma so we could identify behaviours to target in a behavioural intervention for general practitioners. The integral part of this research is that it is informed by the patient experience and it is also informed by the needs and wants of the practitioners that it's going to be delivered to. So I'm going to briefly talk through the first study in the PhD which has been completed and submitted, and fingers crossed we'll have it early next year. So we'll talk through the patient perspective through the lens of the qualitative evidence synthesis, looking at the perspectives and experiences of enacted weight stigma from the patient's perspective across primary, secondary and tertiary healthcare settings. I'll also give preliminary findings to study 2. We were interested in looking at the GP perspective on treating obesity in Ireland as a disease and how that may or may not impact treatment. We'll also look at this through the Irish adaptation of the Obesity Canada clinical practice guidelines. And I also want to end on a positive note while we look to the future, because we have the model of care for overweight and obesity that we hope to implement it soon in Ireland. So weight stigma in healthcare is thought to be due to a lack of understanding of the complex interplay of factors that contribute to the onset and maintenance of obesity. This is largely attributed to false attributions around the controllability and causality of weight. And unfortunately, there's large emphasis, as we've heard from Stuart today, around eat less and move more, which we know is not an accurate reflection of contemporary obesity medicine or obesity research. Despite key stakeholders agreeing that obesity is a disease, patients continue to experience denigration and discrimination across primary, secondary and tertiary healthcare settings. This is the name of our review, and this is the team. So Dr. Caroline Heary, who is also the chapter lead on reducing weight bias in the Irish adaptation of the clinical practice guidelines. We have the lovely Susie Burney, Dr. Michael Crotty, we have Jane and Owen Conlon, my supervisors, we have Rory Coyne, and we have information specialist Rosie Dunn, who we could not have completed our qualitative evidence synthesis without. So I want to mention her today. We ended up including 32 studies in the synthesis with a total of over 1,300 participants across primary, secondary and tertiary healthcare settings. I just want to mention that out of the amount of participants that we included in the study, only 3% were male. So this just really reflects a drastic gap that we have in our research of a deeper understanding of the male perspective of weight stigma across primary, secondary and tertiary healthcare settings. So we use a thematic synthesis following the Thomas and Harden approach. The reason we followed this approach is that we wanted to stay grounded in the patient perspective, but also using this approach allowed us to identify patterns across the research to identify higher order themes, of which we found 3 interconnected overarching themes. The first one being devaluing and disempowering the patient through interpersonal reactions. This was represented through disrespectful dialogue and non-verbal cues. Disrespectful dialogue has been spoken to today across all of the speakers, and how that's represented in the literature is that people face discrimination and denigration through the demonstration of verbal stigma. And this is iterated throughout the literature through blaming and shaming patients living with overweight and obesity. This is exceptionally prevalent across primary, secondary healthcare settings, and this was reflected in an Irish study completed by O'Donoghue et al. In 2021, where Irish patients discussed their weight stigma experiences across primary, secondary and tertiary healthcare settings. In tertiary healthcare settings, for the most part, patients found they had more of a pleasant experience, and this was characterised by being spoken to with respect, compassion and empathy. This was not reflected in the broader literature, however, where patients found that while initially post-surgery tertiary level they may have been interacted with those exact conditions, that post-surgery the support completely dropped off. And that was within tertiary healthcare settings, and also we'll talk about this later in terms of clinical care pathways to and from tertiary healthcare settings completely dropped off. And this was evident, this review, there was no geographical limitation, so this includes research from Australia, Canada, the USA and across Europe, including Ireland. Non-verbal cues. I included some of the quotes here that are actually quite benign, because some of the quotes that we included, I couldn't actually have them on the screen because they would bring you to tears. Just like you listen to the patient experience today, you've heard from Susie, you've heard from Sarah and you've heard from Johnny. Being immersed in this literature, it's catastrophic. It absolutely is. Non-verbal cues, as Stuart talked about earlier, it was a demonstration of contempt and disgust, and this was represented in the literature from patients not experiencing their healthcare practitioner wanting to touch them to engage in treatment. This is particularly prevalent in secondary healthcare settings in treatment-seeking fertility patients. Losing sight of the whole person. Some of this reflected a lot of the quantitative research that's already there, where patients experience dismissal, referral and refusal based on their weight. So what we found in this research went a little bit further, where we did see the oscillation between dismissal of non-weight related concerns in the presentation of ailment within primary practice mainly, to catastrophising potential risk in treatment-seeking patients and catastrophising potential risk in preventative care settings. Reduced to a metric was the name of my talk, because essentially that's the greatest message that was taken from this qualitative evidence synthesis. People were being denied access to care based on BMI. People were being sent for treatment against their will in a non-collaborative approach because of their BMI. And again, this was very, very prevalent in secondary healthcare settings, particularly in treatment-seeking patients for fertility. This left patients feeling it was a non-collaborative approach. They had no choice. They had lost their autonomy in choosing, lost their autonomy and their control over choosing their own care pathway. And that, I think, was the strongest message out of this qualitative evidence synthesis. While it highlighted the quantitative research that is already very, very prevalent, it gave us a deeper and broader understanding of the severity and the impact of weight stigma on a person's psychological well-being, on a person's willingness to engage in healthcare. And also, you can see where the tendency is there for people not to want to go back and also expect differential healthcare treatment, which leads to an increase in comorbidities and ultimately mortality, which we've heard about Susie's friend. And that's also down to a lack of clinical care pathways. Which brings us to the next theme, which was systemic issues. Drastic lack of consistency in the delivery of care. And this was represented not only by poor clinical pathways across the globe. This is also represented by poor environments being presented to patients living with obesity that did not accommodate higher weight. And this is as simple as making sure that there's chairs there that can accommodate a person living with higher weight. Are their gowns going to fit? Do not weigh a person in a room full of other people. Common decency seemed to have been neglected across obesity care in primary, secondary and tertiary healthcare settings. Update the outdated advice. Do you know, and a really interesting finding across this was that not one time across the literature did we find a patient that didn't want to talk about their weight. They were quite happy to engage. It's how they were spoken to where the problem lied. People wanted to learn more about, well, eat less, move more. This was really common. Update the outdated advice is eat less, move more. Eat what and move in what way? And that was a recurrent theme. We're happy to engage, but tell me how. And we'll speak a little bit about this to the next study. This is greater than just healthcare practitioners having a bias. This is a systemic problem. We also collected patient suggestions on how to reduce weight stigma across primary, secondary and tertiary healthcare settings. Patients' voice is absolutely paramount across the board. And it was interesting that out of 32 studies, only 13 included a question that asked the patients how they felt they could reduce weight stigma. These were the findings. Patients wanted to be demonstrated empathy, as Stuart spoke about earlier, have a non-judgmental approach to healthcare concerns, listen to the patient, actively listen to the patient, use respectful language, person-to-person language. Do you know, it's interesting as a psychologist, my background is counselling psychology, but we're taught the core conditions, which is to communicate the core conditions, empathy, non-judgmental or positive regard, and be genuine in how you approach a patient in this instance. That's the basics. So we're taught it doesn't matter what you have in your toolbox, if you do not treat your client with respect, you're going nowhere. And it's interesting to me that this is not common sense, but I know I did talk to Laura earlier on. Unfortunately, that seems to be omitted in lots of areas of life, and this is not one that's omitted from that. But essentially what patients wanted was a collaborative approach to addressing health concerns where they felt that they had control over their own healthcare requirements while negotiating their healthcare system. Ask about my history. Ask about my history. And this has come up numerous times today, where patients are presenting with a complaint and there is no investigation of previous weight loss attempts and any extraneous variables that may be contributing to weight management at that point in time, such as medications, depression, anxiety, so on and so forth. The relationship with healthcare practitioners was seen as the greatest source of enacted weight stigma across primary, secondary and healthcare settings. But it wasn't just that. That interaction migrated then to the provision of care across all of those settings and was seen to mediate access to services, which perpetuates an overall poor systemic infrastructure to support the needs of patients. Patients suggest that we improve the quality of the patient-provider relationship as the mechanism to reduce weight stigma across healthcare settings. A lot of the research that we have around weight stigma reduction strategies are experimental in nature, and we've seen a meta-analysis recently that shows marginal effects and a call for we need to evaluate it over longer periods of time. What we're missing drastically in the weight stigma research to reduce just that in healthcare settings is the patient experience. So everything that we're learning is from the literature, but we need to learn more from the patient themselves, because as we've seen for the QES, while it supported the quantitative literature, it gives us a deeper understanding of the nuances of the patient experiences that can't be ignored. Very tentative preliminary findings around a GP study that we have at the moment investigating the perspectives of GPs on treating obesity as a disease in Ireland and how that may or may not affect treatment opportunities. We have 10, and their experience levels span from 30 years to one particular GP who's just out of GP training. The interesting part of this is that despite the level of education and the amount of time, verbatim is that obesity is framed as a risk factor for disease and it is not a disease in itself. So that's coming from the GP who's been practicing for 30 years and from the GP who's just fresh out of training. We haven't changed. The way it's presented, it stigmatizes, it causes X, Y, and Z. Now we know again from the quantitative literature that I'll pick on them at the moment, I'm sorry, it's just because they're in my study. They go into medical school, and by the time they leave, their implicit bias is higher for overweight than they were when going in. And we know that's because their educators, their trainers are actually emboldening that belief that obesity is a refractory ailment, because oversimplistic approaches to treatment of obesity, calories in, calories out, without taking in any consideration of the complex interplay of factors that we now know that are reflected in contemporary obesity medicine, are not taught in medical school, and the same is here in Ireland. The problem is our education system. Well, I'm not, just to play devil's advocate, if you're taught through your whole training that this is a person's fault, how are you going to engage any differently? That's not an excuse, because I don't advocate that as an excuse, because I hear time all the time being a reason why we can't engage properly with patients living with obesity, and that's absolute nonsense, because you can convey to somebody pretty quickly you have respect for them, you can empathise with their situation, and you're not judging them because you're there to do a job, irrespective of how you feel about that particular ailment. At the moment, there is only one focused educational module in Ireland, or course, which is the Obesity Masters in the University of Galway. No other part of the medical training is integrated at higher level education. Now, we've heard from Susie that we're working towards that. It's going to take time, but I just think that's something that we need to come back and focus on a lot, because it needs to change top down. From a training perspective, GPs felt that they were unequipped to initiate weight-based conversations, that it was taboo. They felt they weren't trained to address these conversations, and many of them avoided it. They felt it was the elephant in the room, was the quote that I heard quite a few times, and they didn't want to state the obvious to the patient in fear of upsetting them. What we know from the literature is that patients are actually quite happy to engage in these conversations once they're engaged with respect. There is a lack of a structured care pathway available for referral. Described feeling powerless, and that they felt that this overburdened them, and that they felt it was harder and harder to deal with patients living with obesity, because they felt that they had nowhere to send them for help, even though change was slow, and they acknowledged that obesity wasn't as simple as eat less and move more. They felt that they had nowhere to refer to, and I heard Slimming World mentioned earlier, I think it was from Sarah, and that's essentially where they're being told to go, because the waiting lists for dietitians and nutritionists in Ireland are outrageous. We have 2 weight management clinics in Ireland, one in Galway, one in Dublin. Pre-COVID, the waiting list was 5 to 7 years, and I fear what it might be at the moment. So our takeaway findings from preliminary findings is that we do need to require, GPs require contemporary education on the complexity of obesity across medical settings. We need training on how to have weight-based conversations. Clear clinical pathways to refer. Recognise the oversimplification of current methods, but yet felt powerless due to poor current systemic infrastructure that's in place. They were supportive of the model of care for management of overweight and obesity. This is the problem that we have here, is that all but 2 of them had even heard of it. 5 of those were academic GPs in academic institutions dotted around Ireland. And the 2 that had heard of it, one of them had attended a lecture from a very prominent GP who spoke about it, and the second one had done the Masters in Obesity in NUIG. So I think that's something that we need to keep in mind. Sometimes when we're working in an area, we think everybody knows what we're talking about, but unfortunately, if it's not being communicated to the integral stakeholders, what's the point? So if we consider all that within the Irish context and the Irish adaptation of the clinical practice guidelines, what is the state in Ireland at the moment? So we know from our research that 60% of adults live with overweight and obesity. There are higher prevalence rates in marginalised populations. At the moment, and this when this research was originally undertaken, which is a year ago now, so this could have potentially changed, 7.9% of Irish adults over the age of 50 currently meet the criteria for bariatric surgery. We have a 2-tiered system here in Ireland where it's private and public. If you're in the public system, our current capacity to meet those requirements is 0.1%. Not good enough. We are lacking clear clinical pathways across healthcare settings, and that has been iterated through Study 1, Study 2, and the literature. Public health messaging, to back up what Stuart had said earlier, is a huge problem. Because not only in our education institutions are we oversimplifying the treatment of overweight and obesity, at a population level we're hearing eat less, move more. All of us have. Oversimplified public health messages, what do? Well, they facilitate the social narrative that place the burden of responsibility of the person living with overweight and obesity, and all that does is impact a culture that's already there that moralises obesity as a personal failure. An overemphasis on quantifiable measures of health. Weight is not a behaviour, yet we still focus on that. We have a lack of focus on the structural and societal changes that are necessary to see change. And I love that Stuart added in the Healthy Ireland report. I did not have the backbone to do that earlier, to be quite honest. So when I see it, I was overjoyed. That's a problem. That's not old. So what does this do to the patient? They're internalising all this. We all internalise all this. But for the patient living with overweight and obesity, how are they impacted by that? They expect different healthcare treatment across primary, secondary and healthcare settings. to the point that people will not engage in healthcare services, and we've heard that from Susie today. There's people behind those statistics, as Susie said, and I think we really need to keep that in mind. There was an Irish study done by Grinnell et al., which looked at obesity causation and treatment in Ireland, and what was really interesting about this particular study is that the patients involved in the study identified obesity or accepted obesity as a chronic disease, but yet identified lifestyle factors, eat less, move more, as the most prevalent way of treating obesity, and described willpower as the determining factor in treatment efficacy. Just let that sink in for a second. So I acknowledge that obesity is a disease, but you're not treating it as a disease, and I'm accepting that. I'm accepting this is down to me, it's my personal responsibility. I eat less, I move more, and if I can't do that, it's my fault. That's not okay. And I think in a bigger picture is that it imposes a barrier to the prescription and uptake of alternative, more appropriate interventions, such as pharmacological interventions and bariatric surgery. So the summary of the recommendations to reduce weight stigma within the Irish context is well put by Dr. Cathy Breen. That education is required for all healthcare professionals to address the gap in skills, increase knowledge of evidence-based practice, and eliminate bias and stigma across healthcare settings. People with obesity should have equitable access to evidence-informed care, including medical and allied health services, including equitable access to pharmacotherapy and bariatric surgery, and a call for the implementation of the proposed model for care for management of overweight and obesity in Ireland. I don't want to end on a sombre note, so just to put out there that this is out there, and hopefully the funding will be put in place that this will be able to be integrated into our healthcare system sooner rather than later. The mission statement for the model of care for overweight and obesity is that a core target for reform is the elimination of weight stigma in healthcare through systematic education and training that reflects contemporary developments in obesity research. The model calls for and outlines changes in structural, educational and training requirements necessary to facilitate a need for equitable and timely access to healthcare to improve the provision of care for overweight and obesity. And they recommend this is done by mapping the model of care to align with the national framework for the integrated prevention and management of chronic disease in Ireland, because that is exactly what obesity is. Take-home points. As we've seen today, weight stigma is very prevalent, as well documented by Dr. Stuart Frint across healthcare settings. Outdated eat less, move more attitudes towards the treatment of obesity contribute to the stigmatisation of obesity, which ultimately undermines healthcare provision. Education training is required for all healthcare professionals across all healthcare settings. The implementation of the model of care is a necessity, and probably the most fundamental take-home point is that the patient's perspective is integral to the success of any obesity-related policies, obesity research and healthcare planning. Nothing about us without us.